Afternoon is Hugo Penny. Hugo is a trainee here in Sheffield and South Yorkshire, and his particular interest is celiac disease. He's going to talk to us this afternoon about non-responsive celiac. Thank you, Hugo.
Thank you. So we know celiac disease is a small bowel enteropathy driven by a loss of immune tolerance to dietary gluten in genetically susceptible individuals, and that most individuals with celiac disease improve following a gluten-free diet in a matter of weeks to months. But around 15 to 30% of patients will continue to have symptoms despite a gluten-free diet. And when those symptoms persist for more than 12 months, we tend to refer to these patients as non-responsive. But actually, we know that non-responsive celiac disease comprises this broader group of conditions that doesn't only mean they get symptoms related to dietary indiscretions, but some patients also have additional diagnoses that drive their symptomology. And only a small proportion develop true refractoriness to gluten with persisting inflammation. And with refractory celiac disease, we typically subcategorize it as type 1, in which case the mucosal inflammation is very typical of celiac disease, or refractory celiac disease type 2, in which there's this expansion of what we call aberrant intraepithelial lymphocytes. And it's those aberrant intraepithelial lymphocytes that puts patients with RCD2 at risk of malignant transformation to enteropathy-associated T-cell lymphoma. And these patients also have a significant increased risk of developing other complications such as ulcerative jejunitis. So let's put some numbers to this. So we looked through all the patients with confirmed celiac disease seen in our centre over the last 20 years, and we've been following them up. And about 13% of those patients have come back in with ongoing symptoms under this broad title of non-responsiveness. And we've worked those patients up closely to try and determine what was driving their symptoms. And we noticed that around a fifth of patients have issues with ongoing gluten exposure. And I think that really highlights the difficulty for some in maintaining strict adherence to a gluten-free diet. A small but important population of patients didn't actually have celiac disease on further testing. And this has also been described in other studies in non-responsive celiac disease. And I think there's a really important practice point here that in particular groups to be aware of are those that maybe have a historical diagnosis of celiac disease. So serology testing in celiac disease before 2000 was not as accurate as it is now. Also, patients in which the index diagnosis, the veracity of the index diagnosis may need to be revisited are those with seronegative celiac disease, because we know from Imran Aziz's paper in Guts a few years ago that there are a number of different causes of seronegative villus atrophy, of which celiac disease is one. And it's really important to exclude those other causes before making a diagnosis of seronegative celiac disease. And in cases of uncertainty of that diagnosis, patients can have HLA typing. So owing to the exquisite relationship between HLA-DQ2 and DQ8 and the development of celiac disease, it has a powerful negative predictive value. But a more formal approach to confirming that diagnosis would be a gluten challenge and rebiopsy. Also, what became apparent was that more than half of the patients had an additional diagnosis that was causing their symptoms. And we know from studies that there are a number of conditions that are associated with celiac disease. And so it really underscores the importance of taking a systematic approach when seeing these patients in clinic. And when doing so, a really important step is to repeat the duodenal biopsy to check for the presence of ongoing villus atrophy. And that's because surrogate markers such as serology and adherence questionnaires, etc., perform quite poorly at identifying patients with ongoing villus atrophy. But in those individuals that do have persisting mucosal inflammation, really the clinical decision point is to decide whether this is due to non-adherence to a gluten-free diet, whether the patients are suffering from slow healing on a gluten-free diet, or whether they have refractory celiac disease. And that can be really hard to unpick, mainly because there's no diagnostic test for either of those three scenarios, and mucosal healing can take years in some patients. And so you may need to adopt a watch and wait approach or undertake serial biopsies in some individuals to see whether there are improvements in that mucosal inflammation. That said, there's evidence that suggests that gluten immunogenic peptide testing may provide of clinical use in identifying patients that have dietary transgressions. And certainly there is emerging evidence of note from this group over in Spain that suggests that the presence of gluten immunogenic peptides in urine samples of patients may provide an indication of gluten ingestion and dietary indiscretion in the previous 1 to 2 days. And so we took this test and we applied it to some of our patients and asked a really simple question, and that was that in those that were recently diagnosed with refractory celiac disease type 1, was there any evidence of ongoing gluten ingestion? And we asked patients to provide us with 3 urine samples, 1 during the week and 2 over the weekend. And when we analysed their urine GIPs, quite remarkably, we found that about half of the patients had evidence of a positive test. And when we went further into the data and we looked at the presence of the number of tests that were positive, we identified that about a fifth of patients had evidence of multiple GIP positive tests, providing quite strong evidence that dietary indiscretions are ongoing in these individuals, and really highlighting the difficulty of picking apart mucosal inflammation from ongoing gluten ingestion and refractory celiac disease, and really also identifies that this might be a clinically useful test that we introduce into clinical practice. So refractory celiac disease type 2 is slightly different, and making a diagnosis is really centered around identifying those aberrant intraepithelial lymphocytes. And in Sheffield, we do this by flow cytometry. So we take the duodenal biopsies, we isolate the intraepithelial lymphocytes, and we tag them with fluorescent antibodies and analyze them on flow cytometry. And that provides us with a really clear surface map of the cell, and we're able to identify those cells that lose surface expression of the CD3 protein, which is the identification of them as being the aberrant phenotype. And it's really important to remember in patients that you suspect or have diagnosed refractory celiac disease type 2 in, to perform a longitudinal assessment of the small bowel. So small bowel capsule endoscopy is a really good way of doing that, just to really get an idea of the disease extent in those individuals. And cross-sectional imaging is also incredibly important in those patients. It's also worth saying at this point that you can identify that aberrant phenotype by more routine immunohistochemistry, and certainly other centres will do that. But the evidence suggests that flow cytometry is a more sensitive approach at doing this. And if there are other centres out there or clinicians that have patients that they suspect might have RCD2, they're more than welcome to get in touch with us. We are the National Centre for Refractory Celiac Disease, and we do take referrals. Once you've made the diagnosis of RCD1 or 2, the treatment options are as such. So RCD1, the inflammation subsides quite well on a combination of oral steroids and steroid-sparing agents. We don't use immunosuppressants such as azathioprine and RCD2 due to the increased risk of lymphoma in these patients. And actually in RCD2, although there are a few treatment options, there's no real evidence that any treatment in RCD2 prevents the progression to enteropathy-associated T-cell lymphoma. And we know, and this is the graph shows our outcome data from our patients, and certainly the 5-year prognosis in RCD2 is poor in comparison with other types of celiac disease. And so the take-home message is that ongoing gluten exposure is the commonest cause of persisting symptoms in these individuals, and that actually we're now assimilating information and data suggesting that GIP testing may be helpful in differentiating RCD1 from those with ongoing gluten exposure. And finally, RCD2 is difficult to identify, is difficult to manage. We are a national centre, and please do get in touch because we can provide advice and support. With that, I'd like to thank the team at Sheffield for both setting up the clinic and compiling the data, and just to re-highlight that we have this centralised service across Sheffield and Cambridge. Thank you.
Thank you, Hugo. A couple of questions have come through.
Fabulous.
So the first one is, I think, an exam question. How common is HLA DQ2 and 8 in the background population without celiac disease?
So about 30 to 40% of the population have the HLA DQ2 or DQ8 phenotype. And we know that about 1% of the population have celiac disease. And I think that raises a really interesting question as to what causes that loss of immune tolerance in those patients. Thanks.
The next question is, there's some interest in these GIP tests.
Yeah.
So the question that's asked is, in the study you talked about, were patients blinded to the purpose of the test? And then also as a follow-up, how long do people stay positive after they've taken the gluten in?
So the data suggests that the GIP positivity in the urine gives us an indication of gluten ingestion over the preceding 1 to 2 days. In terms of the blinding, yes, we ask patients to provide a urine test for part of their treatment.
Okay. And how far away is that from being a clinically available test?
I still think we need to assimilate more information and more data, and we've got ongoing studies looking at this further. Yeah.
Okay. I've got time for one more question.
Great.
What percentage of people with RCD2 go on to develop a lymphoma?
It's difficult. So in the context of RCD2 being a very rare condition, the data is fairly variable across different sites. But when we look at our data, it's about 30% of our patients with RCD2 progress to enteropathy-associated lymphoma.
Thank you very much.
Thank you.
Thank you.